welcome back to episode 5, season 3.0 of Medical Today with me, Jared Ratnam. We did have a very interesting first segment talking about laser therapy, speaking to Shahzar Ahan, a guy who's at the forefront of laser therapy in Malaysia. From there, we move on to pediatrics. We spoke to an interesting pediatrician last week. I had the chance to go to KPJ Damansara and to speak to a neonatologist who's a pediatrician, and he deals with premature babies. We also took a look at what an ICU for premature babies is or is called. It's better known as a NICU or NICU. We'll find out more about that in this interview. Let's take a look at me speaking to Dr. Mohammad Iqbal at KPJ Damansara. Here's that video. Dr. Iqbal, thank you very much for taking time off your busy schedule. I know there are quite a few patients waiting out there, and you've got a long list on clinic days. What is one day like for you in a clinic? How hectic can it get?
It's very busy, but also very interesting because I can get anything under the sun. Mm-hmm. A child can come in with various ailments. You may be respiratory. You get the usual cough and cold, mm-hmm. but sometimes you can get some of the nebulous conditions as well.
Right.
That challenges you. And seeing kids just sometimes also makes my day. That's one of the reasons why I took up pediatrics, mm-hmm. because no matter how sick the child is, with the right approach, you can make them smile.
Right.
And when you make a sick child smile, it makes your day.
So before you got into pediatrician, just after doing general medicine, what was it that gravitated you towards pediatrics?
Well, obviously, when you're a medical student, you rotate during various specialties. One thing I noticed about pediatrics is the consultants were much chirper, happier. Mm-hmm. They have got
so you kind of like that vibe, yeah.
And the wards were brighter, and you got a happy ambience compared mm-hmm. to a geriatric ward or an adult ward. And children, as I said, they can get sick with various ailments, but they get better quicker as well.
Right.
And when they get better, I like the interaction that you get when you interact with them.
So generally, you are a person who is very much into a vibe or vibes. Yeah, when your patient walks in, you feel their vibe also.
Definitely. You need to do that. You need to be, and also you need to present a good approach, a happy vibe. Because sometimes a child may be well, but it's the parents that you have to manage. Because mm-hmm. the parents may be inexperienced in dealing with simple things like fever. Mm-hmm. The child may have just a normal viral illness, which all they need is advice on how to manage the fever and what to look for if the child gets worse.
Right.
So sometimes the child is fine, it's the parents that you need to mm-hmm. focus on.
Mm-hmm. So it's interesting that you're a pediatrician and you're also a neonatologist. Maybe let's talk a little bit about what neonatology is all about.
Yeah. So neonatology is a branch of pediatrics. We deal with children or babies, shall I say, who are born early or babies who are born who are very sick at birth. So premature baby are babies who are born before 37 weeks gestation. A normal baby will born at 40 weeks 37 weeks and above. We also deal with the very premature babies who are born below 26 weeks gestation. These are the very fragile and vulnerable babies.
Right, but having said that, sorry for cutting in. When you talk about neonatology, it's also the facilities that come along with neonatology, which is important, right?
Because these babies are very sick and very fragile. They need help with their breathing, blood pressure. So you need specialized equipment in order to manage them. They can be as small as 450 grams. So a baby can fit in your hand. Mm-hmm. So obviously these babies are very fragile and immature in their organs. So you need specialized expertise and equipments to manage them.
So from one child to the other, in your area of speciality and subspeciality, it's always a learning curve for you.
It is. I mean, I'm still learning. I've been in pediatrics for about over 20 years.
Wow.
And I'm still learning. You can never stop learning when you are in medicine. And also advances in medicine force you to learn, to keep it up.
Right.
With the pace of advancements in pediatrics, especially with neonatology. Many things are happening in neonatology. 20 years ago, babies at 23 weeks hardly survive. Now we have managed to increase the survival to about 30 to 40%. It does mean that majority still don't make it, but it does also mean that those who are hopeless before, there's some hope at the end.
So is it technological advancement or advancement in medicine, or the way the approach is that has brought us to where we are?
It's a combination of both. Obviously, how we know more about neonatology from the research that's been done into it. So we've got specialized, more advanced equipment to manage them.
Right.
We also have more knowledge to understand how babies premature function and what are their needs are.
Right. So when you talk about facilities, I guess you're talking about incubators, IVs, feeding tubes, lines. So the hospital in and of itself should specialize in having facilities like this.
Yeah, in order to manage these fragile babies effectively, you need specialized equipment. You need specialized ventilators. We have one of the most up-to-date ventilators in the country. We also have ventured into areas that not many people venture. For example, babies who are born sick because of lack of oxygen for various reasons, we now have cooling equipment where we can cool the baby's brain to minimize damage that result due to the lack of oxygen when they are in the mother's womb.
Right.
So all this specialized equipment needs specialized expertise. So it comes both, you need equipment and expertise to manage this complex
So
babies.
what you're doing, while it's very technical and it's very intricate, there's also, it needs to be something you love doing. It can't be clinical.
You need to have a passion for it, because these babies are very sick and they are there for a long slog. So a baby born at 23 weeks will probably be in the neonatal intensive care unit for about 2 to 3 months.
Right.
And you need to enjoy what you do because it can be quite intensive.
So you have to monitor them from what we call a newborn ICU or NICU. That's the acronym you use. So you are on call 24 hours. If there's anything, you'll be called back to the hospital?
Yes. The good thing about the setup in KPJ Damansara, there are 2 of us. In some private hospitals in the country, there's only 1 neonatologist. In KPJ Damansara, we've got 2 of us, me and Datuk Musa, and we work with each other.
Right.
So we cross-cover each other so that we always make sure that there's a specialized neonatologist around to manage these babies.
Okay, just running off the grid here and digressing just a little. When you talk about neonatology in the country, how many people do we have?
There are not many of us. From the register, there are probably about 150, 200 of us around. Most are concentrated in the Klang Valley, and most are concentrated in the public hospitals.
Well, if you're listening to a noise in the background, it's all the kids who are waiting out there, and I'm stalling them from coming in. But we're going to speak to a few of the parents as and when we get the time right here at KPJ Damansara. In the meantime, coming back to you. So you have an ICU for newborns, also known as NICU. Now, when does a child need to be put in an ICU or admitted to an ICU?
Yeah, when they're unwell. They may be unwell for various reasons. Most commonly, it could be due to infection, prematurity, or any respiratory problems. So they need help with their breathing. So in the NICU, or the Newborn Intensive Care Unit, we've got specialized nurses who work with me and Dr. Musa to manage these patients.
And are these nurses trained by you?
They are trained by us and also trained, because they undergo a specialized training program set by the Kementerian Kesihatan Malaysia. So all of them need specialized training in order to enable them to know what to do when they manage.
Right. So while they have that general training or the general area of speciality, when they work with you, you have things that you like done in certain ways.
So we do explain to the nurses what are the things that needs to be done, and they also understand from their own training as well, because all of them do undergo specialized training done by critical center.
So in your area of specialty and subspecialty, I guess you'll be looking at a lot of jaundice cases, neonatal sepsis. Can you kind of, to say dumb it down is not the right word, but can you simplify it for us?
Right. So in our unit, we have the NICU, which is the neonatal or newborn intensive care. These are the ones that we use to look after the very sick babies. Then we have the special care baby unit. The special care baby unit we use to look after babies who are jaundice. Jaundice is a very common thing. About 80% of babies get jaundice.
Yeah.
It's a very physiological phenomena.
But in premature babies, it must be a little bit more difficult to deal with, isn't it?
Yes, because they are more vulnerable of getting the effects of jaundice, and more common for them to get jaundice. But what we do is we want to make sure that the jaundice that the babies get are not detrimental to them, because if we're not careful, they can have long-term brain damage from the effects of jaundice. So in our special care baby unit, we have specialized equipment called phototherapy that we can use to minimize baby's jaundice.
Now, I was asking about neonatal sepsis also. Apparently, for those of us who are not in the know, it's a blood infection that occurs in an infant younger than 90 days old. Now, what is the cause of neonatal sepsis, and how do you, as a specialist, detect it?
So, most common cause of early onset neonatal sepsis are infections that the baby gained from the mother. And what we know that some of these babies get group B streptococcus infection. So group B streptococcus are a normal common cell, a normal bacteria that up to 30% of mothers carry. It doesn't affect the mothers at all.
Right.
But if this bacteria gets into the baby's bloodstream, it can be fatal.
Right. When you say baby's bloodstream, are we talking about premature babies or just...
Or even term babies.
Term babies,
so term babies can get the same infection that premature babies get. Obviously, premature babies are more vulnerable. So what we do is we need to manage them with antibiotics, manage them with hydration, and also making sure that they breathe normally. Because some of these babies may need help with their breathing.
Which brings me to chronic lung diseases or respiratory problems. A lot of the problems that we hear about with regards to premature babies or full-term babies are due to respiratory problems, and with the problems we have with our environment these days, it's becoming more prevalent. Now, what do you see in your area of specialty or subspecialty?
So we get a very varied case mix in our practice. So the premature babies, we get babies with respiratory distress syndrome, and that is a condition as a result of immaturity of the lung.
Right.
So some of the babies may need ventilation to help support the oxygen exchange and carbon dioxide exchange that they need. Some babies are born with this horrible condition called meconium aspiration syndrome. This is a condition where in utero, when baby's in the womb, baby pass motions early, and they take the motions into their lungs. So you get a bit of poo, meconium, in their lung, and that can cause horrendous problems to these babies. And these babies need specialized types of ventilation. More often than not, they may need high frequency ventilation, which we will be able to administer. There are other conditions where a newborn baby may be born with a puncture in the lung for various reasons. And we need to, again, manage babies actively with chest drains, and again, putting babies on ventilation if they are not able to sustain their own respiration. Pneumonia is another condition where we sometimes manage, most of them are able to be managed just with antibiotics and oxygen, but some are much more affected and needing ventilation.
So I'm guessing by the words you're using, and correct me if I'm wrong here, it can be managed, which means it's going to be a problem lifelong, or it can be reversed.
Most can be reversed in this condition. Most children who have problems at birth can be managed, and their condition can be limited.
Right.
So they don't have the severe effects afterwards. There are some conditions, for example, babies with chronic lung disease, and that is the condition that occurs almost exclusively in premature babies.
Right.
These babies, when they are born, their lungs are very much more fragile. So these are the babies who tend to have lots of cough and cold more than babies who are born term. So this needs to be managed by their pediatrician long term.
Right. I mean, this conversation can go on for a while because there's just so much to deal with, especially with premature babies, also with full-term babies. But I guess the other important person here would usually be the mums. Now, you know, they would, during pregnancy, they would develop depression, gestational diabetes, hypertension, just so many things can happen during a pregnancy. What are your thoughts on this?
So the mums are normally managed by our fellow OBGYN. So they will be managed by them, and their clinical conditions managed by the OBGYN colleagues. But when they have a baby admitted to the special care nursery or babies admitted to the NICU, they can be under extreme stress and emotional distress. So, and a lot of them, they have no experience dealing with a premature baby. My role with as parents is to bring them along in our journey to make the child better, because it's a partnership. I don't like the paternalistic approach. I want the parents to understand why we're doing the things that we are doing on their babies. Because at the end of the day, it's their baby.
Right.
So I try to explain to them the condition, the treatment, and what are the future outcome. Sometimes you have to tell them the bad from the good. And this is very important, to be transparent.
Right.
I don't like to paint a rosy picture when the reality is not. And I think being honest, being truthful, being transparent with the parents are very important.
Right. Very quickly, we've got another 30 seconds. To wrap this up, what would be one of your greatest moments being a neonatologist?
I think the greatest moments I have has always been looking at these babies who are very sick, who are at the age of death, coming back 2 or 3 years later, jumping up and down in my clinic, causing havoc. I would love that.
On that note, thank you very much, Doctor. It was a pleasure and an honor speaking to you. Well, I'm Jared Ratnam reporting from KPJ Damansara. We just spoke to Dr. Mohammad Iqbal Sarwar. He's a specialist at KPJ Damansara. So today we've learned about pediatrician or pediatrics and neonatology. We'll try to bring him into the studios at some point to have a bigger and stronger discussion with regards to this. Well, we've heard you talk a lot about pediatricians, pediatrics, neonatology, and neonatologists. Now, I guess we need to see you in action for a while. So what we're going to do is we're going to see Doctor do his thing, and I'm just going to sit in the background and be as quiet as I can. Or if I'm lost, I'm going to ask some questions while he's treating the patient. Is that okay with you?
That's fine. That's fine.
Okay. Let's bring in the patient.
Okay.
Yeah.
Good.
Ooh,
Harith?
this is interesting.
Hi. Hello, Harith.
Hello.
Come in, come in. Hi. How are you? High five. Yay. So, Daddy, have a seat. So, Harith not well today. I heard. Yeah. So, what's wrong with you, Sam? Huh?
I was coughing so big.
You was coughing. How long have you been coughing? How many days?
Friday.
Friday? 5 days? That's a long time. So, right. So, dia batuk dah banyak lama dah? 2 hari?
Tak, satu setengah hari.
Ah.
Batuk tu macam orang besar.
Batuk kahak ke? Ah. Any fever tak? Any
Fever this morning. Is like,
this morning? How high was fever this morning?
37 something.
7 something. So, you know, did you take any medicine?
Yes.
What medicine did you take?
I think the green color one.
The green color one. Was it nice or was it yucky?
Nice.
Nice, okay. And did it help the medicine?
Yeah, the fever.
Is this the
went down.
Fleming?
The fever one?
The fever one?
Yeah, it came down.
Uh-huh.
So because of the cough, only running because of the
the sound. When he slept last night, dia tidur, dia ada terbangun tak daripada tidur?
Sikit.
Sikit okay. Anyone else in the family yang tak sihat?
No.
Dia seorang aja.
Dia seorang.
Have you been away mana-mana ke?
No, only
Tak ada.
daycare.
Daycare. Okay, we'll have a look.
So it's very very interesting that you're doing this now. Like if you find out that the child is wheezing, what happens? Do you treat them in-house or?
So if the child is very unwell, let's say need immediate treatment, this is not going to be the environment that we do things. We probably need to transfer you to the accident emergency department. I've had a patient coming to my clinic fitting, right? So when that happens, they need specialized equipment which I don't have in my clinic. I would then bring them to the accident emergency department to manage them there. Whereas many children who come to my clinic here are in a setting of, they are unwell but they're not critical. So the cough and colds, the fever, trying to get down to why they're having a fever. Sometimes they are here because of other reasons.
So, I
tummy
mean,
ache, vomiting, diarrhea.
Doing your investigations is very important. Just while you're talking to them in
Yeah,
these 6-7 minutes.
So,
Harid looks like a strong man. Can I get a
Yeah.
fist bump? Oh wow! Thank
so
you very much.
as
Harid.
they come in, I've already assessed him. You can see how he's although he's coming with cough, his breathing is not labored. So I'm observing how he's breathing, his respiratory rate,
Right.
whether he's blue in his mouth. So you're doing the assessment as you are having a conversation with him. Betul tak?
And I also know he's Captain America.
Yeah.
Oh yes! Wow.
Okay, we'll check your temperature like last time, remember? Check. 1, 2, 3. So fever, okay. When was the last time you gave any fever medicine?
This morning.
Morning, tadi tak bagi dah. Okay, well, listen to your chest. Is that alright? Okay. Okay, breathe in and out.
So this is a very important part of what a doctor does. I mean, checking the
in
chest of a child.
and out.
While it looks so simple,
in
there's a lot
and out.
that they can
Can I
derive
look at the
information
chest at the
wise.
back? Okay. Breathe in and out. In and out. In and in and out. Can you cough for me? Just cough. One more time. Good boy. Good. Okay. Just gonna check your chest. So is there any pain anywhere? No. Okay. Just have it now. Can I look in your throat?
Wow, you're doing
see
well,
that?
man. He's doing amazing.
Yeah.
Oh,
Open your
wow.
mouth. Say ah. Well done. Good. Just gonna check your neck. Right? What about your nose? Can I have a look at your nose? Look up. Looks alright. Good. Okay. So, the lungs looks okay. There's a bit of phlegm in the lung, but there's no serious wheezing. Remember last time
Yeah.
when Hari was really bad, dia
Yes.
ada wheezing kan?
Yes.
And masa tu dia punya breathing pun nampak lain. Dia macam macam tu. Dia tak ada sekarang ni. So, sekarang ni the fever is under control, tak demam dah. And that was also reassuring. So I suspect apa yang dia ada is a viral infection ke. Sekarang pun kita tengok debu banyak and that may cause them to cough. So at the moment, apart from fever medicine, ada ubat lain tak yang bagi?
Clarinet and then the throat.
Clarity dengan promethazine.
Throat, yes.
So promethazine dah berapa hari dah makan ubat tu?
Promethazine only aspirin lagi because there's only one time.
One time. Yang promethazine tu lah?
Yes.
Okay. So I think it's something that you can continue. I know how Harith is. He's got very sensitive airways from previously kan.
Yes.
So I would continue the Claritin dengan promethazine. Promethazine tu will help him sleep at night.
Okay.
And then what you need to look is the fever pattern tu. Because this demam semalam. So fever pattern tu penting because kalau fever dia sekali sehari ataupun fever dia 2 kali sehari baik dengan sendiri, tak apa. Yang kita risau kalau fever tu berterusan, above 38 especially, naik turun, naik turun, naik turun. So bila naik turun macam tu, dia lebih lemah, lethargic, and cough is getting worse, he may need to be seen again. The other thing yang kita nak kena tengok monitor is the wheezing. Kan Harith pernah dapat wheezing.
So while doctor still carries on to speak to Harith, we will wrap this up and of course continue with the rest of the
wheezing
interviews
tu, kalau
right here
perlu
at
wheezing,
KPJ
kena pakai
Damansara.
nebulizer.
I'd like to thank
Macam
Dr.
dulu.
Iqbal for this short
So-
interview and for taking his time.
Harith, nanti kena ambil ubat tau.
Well, that was a very, very interesting video of Dr. Mohammad Iqbal Sarwar, a consultant pediatrician and a neonatologist at KPJ Damansara Specialist Hospital, joining us right here on Medical Today. He has so much fun on a daily basis, but he also saves lives. Thank you very much, Dr. Mohammad Iqbal, for taking time off his very, very busy schedule to join us on Medical Today. We're going to take a short break and come back with more for you right here on episode 5, season 3.0. This is Medical Today.